Hello and welcome to the discussion of today, the endometrial cancer and ovarian. We are going to focus on the updates, okay, of each one of them. As we all know that the endometrial cancer, it has an update in the 2023, which is the Figo, okay, and the Figo classification update was like a very important event, so they are even celebrating the update in everywhere. So you find when you just make a search about the Figo 2023 update, you will find a lot of the websites, a lot of journals speaking about the Figo 2023 update. That's why it's important. Okay, so this one of the important things that we are going to do today. However, we are going to borrow some important concepts in managing the endometrial cancer from the British Gynecological Cancer Society guideline. And why is this? I'll tell you. Because the Figo focused on, the new classification of the tumor or the new staging, but not in details about the histological grading, not in details about the use of the treatment and adjuvant treatment, especially the radiotherapy, because it's already settled, okay? So that's why, we are going, as I told you, we are going to borrow some concepts from the guideline, okay? So before we go and study this whole guideline, which is very lengthy one, okay, we need to clear some concepts, what they are speaking about, okay? So this is what I'm going to do today with you, so that you have the guideline and you must have the Figo 2023 update. You must have tried to read this before, okay? But I'm going here to tell you, okay, the sum up of all of this, okay? So let's clear a point, okay, which is from my experience with teaching my friends. I found that some of you, maybe they have a little bit, of confusion about staging, grading, and molecular testing. So I'm here giving you a simple pathway in your head, okay, on about how we are going to assess a case of endometrial cancer. Okay, so from here you will understand, or you will get an idea about which picture we need to complete so we can decide on the treatment of this cancer. Okay, so the parts of the picture or the parts of the puzzle need to be completed, right? So if the woman presented to us with symptoms of endometrial cancer, which is usually present itself or manifest by bleeding, and this bleeding might be in a premenopausal woman or a postmenopausal, which is more seriously, right? So in the premenopausal, we have heavy menstrual bleeding cases that's not responding to bleeding or, to treatment, or the cases with a high risk of developing cancer. So in this case, if she presented with abnormal bleeding, she will need a further investigation, and the investigation of a choice, either in the premenopause or a postmenopause, in detecting endometrial cancer is simply taking endometrial sampling or biopsy. The endometrial cancer or biopsy need to be taken whatever the method, in the postmenopausal by Bebel or in the premenopausal by and in the high-risk cases by using of the hysteroscopy, right? All of these are point of important when you study the guideline, which is very important in the exam, and I think that it's a straightforward. Do you have any problem, my friend, in how to manage the postmenopausal bleeding or how to manage the cases of abnormal bleeding? Any problem in that? Inshallah, there is nothing. It's an easy one, and the talk of the detecting endometrial cancer is very useful in this regard. So when you take a biopsy, what you will need to do with it? What you need to do with the biopsy is you are going to send it to the lab, right? In the laboratory, we are doing a histopathology. The histopathology is not only going to tell you this is an endometrial cancer, but they will tell you what is the histological type of this cancer, correct? Yes. So they will tell you what is the histological type of this. They are going also to tell you about the grading. Oh my God, what is the grading? Yes, the grading is very important when we speak about the prognosis and the behavior of the tumor. Okay, so we have the grades 1, 2, 3, and of course the tumor histological grade of 3. This is the one that have the higher risk, correct? So the histological grading is needed, correct? So I know I can be aware of the grading from the histopathology of the biopsy. Yes, why not? Okay, and recently the NICE guideline advised, okay, that where it is possible, we are going to test for molecular classification of the tumor. Okay, so the molecular classification of the tumors, this is the, new updating practice. Okay, so we are going to test this tumor for some abnormal genes. Okay, one of the most famous testing that we are doing is the mismatch repair, right? So for the Lynch syndrome, is it only this one? No, it's not only this one. For example, we are going to test for the pool mutation, and we're going to test for the P53, correct? Yes. So molecular typing, okay, is going to be very helpful in managing the cases. And the most important thing is not only in the how it will give you an idea also about the behavior of the tumor, but that there is a new medications, okay, that is now considered as the miraculous, okay, medications, like for example the dostarlimab, okay. So these medications can be helpful, okay. So patient can benefit from the immunotherapy, okay, the new and updated medication, okay. Okay, so now we need to understand for each tumor, I need to know what is the histological type, what is the grade of this tumor, and what is the molecular testing of that tumor, correct? I just want you to know that we need this, okay? How to gain the information, okay? I can get it from the histopathology and from the immunohistochemistry testing, okay? But the immunohistochemistry is going to answer, okay, what is the molecular type of this tumor, correct, guys? Okay, so I have 3 information that are needed, okay? Okay, so I can get this information from the sample of biopsy, or I can take it from the specimen after removal, okay? So then after that, we need the staging. We need to do a proper staging, correct? By the whatever available information. Remember, my friends, that molecular testing is not available in everywhere, okay? And is not done for all tumors, okay? But at least the tumor type and the histological grade is needed, okay? So those are enough for staging. What do you think? Can I have only the histopathology report and I say this is a stage 1, stage 2, stage 3, whatever? No, it's not enough. So I need further, right? I need further. How to take the further information? I can take it from imaging, from as for example, okay? So if I have the endometrial type, for example, okay, of endometrial cancer, I want to assess the depth of invasion. Okay, so what image can help me? MRI, excellent. Okay, so I will advise MRI for this patient. Okay, so MRI can give me the answer, okay, for the depth of invasion. Other useful, okay, testing, like for example, the CT, okay, CT for the abdomen, okay, can help me, okay, to gain more information about this type of the tumor and help me in staging. Okay, if it is a high grade already, Okay, so we can use the CT also for the chest, right? Can I use a PET at the initial assessment? PET scan? No, PET scan is not advised in initial assessment, correct? Okay, it's going to be useful for the cases of recurrence, for example, or metastasis. Okay, so can I get information from the surgery? What do you think? Yes, of course. Okay, so what is standard surgery we are doing in the endometrial cancer? The standard surgery is hysterectomy. What do you think? Simple hysterectomy? Modified radical? What do you think? Which type of hysterectomy you are going to do? Okay, so we are going to do a total abdominal hysterectomy. Okay, good. Okay, good. Yes. Okay. So yeah, my friends. Okay, so we will say that the mainstay of the surgery, okay, will be the total abdominal, okay, pelvic bilateral saphenous oophorectomy with pelvic lymphadenectomy. This is the like baseline, right? Okay. So, dear friends, we need all of this, okay, information so we can decide on further step in the treatment. If there is any further step in the treatment after surgery, so we have removed already the uterus, okay? Is that enough or not enough? So the secret here in the need of adjuvant therapy, right? Okay, so adjuvant therapy, okay, that's the one that means, okay, adding another method or another treatment after surgery, correct? Okay, so if I want to speak about adjuvant therapy, I will definitely need further information about the stage, about the grade, and about, okay, the surgery of this patient, okay, the surgical staging of this patient, correct? Right? So, for example, okay, and it's a very, uh, a very superficial example. I would say, okay, that for a patient who is 1A, okay, 1A1 means nowadays it's non-aggressive, okay, so the grade can be 1 or 2, okay, it's a non-aggressive tumor, okay, and it's confined now to the only endometrium or a polyp, okay, so it's enough to do a surgery. Is it necessary to add a treatment like radio treatment for this case? No, I don't need. Yes. Okay. So those are all the concepts that we have to clear, okay, before we go to the details, to much deep details or a second layer in the details in understanding the endometrial cancer. So here, okay, those are the information that I need, okay, in order to assess a case of endometrial cancer. I need to have the histopathology report, which show the histological subtype. Either it's endometrial, which is the most common type, or serous or clear, or carcinosarcoma, or mixed. I need to know the Figo staging of this case. I need to know the histological grading. I need also to assess the lymphovascular invasion. What is the lymphovascular invasion? Okay, nowadays they are dividing the lymphovascular invasion into, okay, no lymphovascular invasion, focal lymphovascular invasion, or substantial lymphovascular invasion, okay? So this is according to the blood vessels, the lymph vessels involvement, okay? No means no lymphovascular invasion. Focal means less than five or more, means it's substantial, correct? Okay, so those are the information that I need for the clinical assessment. I need also molecular, okay, testing. And as we said, NICE now says that we have to do it whenever it's possible, okay? However, it's not available in all centers, but it's very useful nowadays in the prognosis and in deciding further treatment after the case. So the things that we are testing against, okay, the panel, okay, that we are testing is the pool mutant, okay, or the mismatch repair deficiency, okay, which is the Lynch syndrome status, or the P53 abnormality, which is the most dangerous, or non-specific molecular profile, okay, testing. Okay, guys, so I have the 4 ones. Why it's important to know which molecular subtype, as I told you, it will give you an idea about the behavior of the tumor and the need for further treatment and the benefit, whether or not this patient is going to benefit from the new trendy, okay, medication of the immunotherapy, correct? So there is a rule says that the pool mutant is good, okay, and it has a good prognosis, and we don't usually need adjuvant therapy if the patient found to have the pool mutation, correct? The mismatch repair is having intermediate risk. However, now they benefit very well, okay, from the immunotherapy, okay? P53 abnormality. P53 abnormality, this is the most dangerous one, okay? That's a poor prognosis one, okay? And the non-specific molecular subtype, it's actually non-specific, so it's like intermediate high risk. So clinical information also will help you to decide what to do with this patient, like what is the age, what is the body mass index, comorbidities, okay, socioeconomic status, and blah, 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 okay? Blood-based also testing, okay, this is going to help, okay? And will be in the cancer centers. Okay, my friends? So information from my side, okay, that needed for this exam, again, I'm saying the histological type and grade, and I say that grade had a more importance in deciding what further treatment or adjuvant treatment required, okay? Molecular testing, if it is given, okay? So I need to be able to interpret the result of the molecular testing when it's given. So when they tell you that the patient is tested positive for P53, so you understand what this is mean, okay? And of course, okay, the rest of the clinical information or assessment of the patient. In the guideline, okay, they are following, okay, for the classification of the tumor, okay, or the tumor types, they are following the WHO 2020 classification. What is the WHO 2020 classification? It is dividing, okay, the tumor types into endometrial tumor, serous carcinoma, or clear cell carcinoma, or undifferentiated or mixed or other type, or carcinosarcoma, okay, or neuroendocrine carcinomas. Okay, which one is the more common that we see more frequently with the endometrial cancer? Yeah, it's the endometrioid type. Yes, excellent, excellent, well done. Okay, so I'm explaining, I'm going through the guideline with you now. Okay, what is this? What is this table 9 in the appendix of the guideline? Yeah, this table 9 in the appendix of the guideline, this is for the grading. So the histological grading, and this is also according to the WHO 2020, okay? And the G grade, okay? If there's not assist, okay, so it's X, not done, okay? However, we need to focus here. The grade 1 of the disease, this is a well-differentiated tumor. So you will find in the MQs, okay, where I'm sure that Dr. Madinji is going to post a very good collection of the MQs in your group to practice, inshallah. Okay, it's about, they will give you sometimes in written cases that Miss Sally, okay, she had a tumor, okay, endometrial cancer, and it's found to be from a well-differentiated type, okay, which, okay, confined to the endometrium. What is the treatment? What do you think that does this mean? If it is a well-differentiated, does this mean it's aggressive type or non-aggressive type? It's a non-aggressive, of course. It's a well-differentiated. It has a good prognosis. It doesn't need adjuvant therapy. Surgery is enough. Correct? Yes. Okay, well done. So that description of this, okay, that less than 5% of non-squamous or non-modular gross pattern, okay? In G2, this is a moderately differentiated, okay? Still, we are not severe yet. So it's 6 to 50%, okay, of the non-squamous pattern, gross pattern. Grade 3 is poorly or undifferentiated. So when he gave me in the MQ, undifferentiated tumor. What does this mean, undifferentiated? Means it's a severe type, right? Aggressive, correct? Okay, means it's high risk. So even if her tumor, is small, maybe 1 to 2 cm, okay, and it invades less than 50% of the myometry, okay, still she will need adjuvant therapy or not after the surgery. Yes, she will need. Okay, so now, my friends, I hope you understand that histological grading is going to give you different, okay, treatment option for the same staging. Correct or not? Yes. So all your recalls in the endometrial cancer and take care, I'm saying recalls and book questions, okay? Before the 2024, they are asking in particular about this point, asking about well-differentiated tumor, early stage, no adjuvant therapy. Poorly differentiated, even if it's an early stage, need adjuvant therapy. This is the common question, correct? Okay, so even if you have a question about this now, you will be able to answer or not? Yes, you will be able to answer. Okay, so my friends, let's have a look. Okay, and Dr. Isra, she have a good question, okay, which will be answered in the next slide. Okay? Okay, Dr. Maria, my dear. Hi. So, look, my friends. We agreed, okay, that the grading is going to affect the risk of the patient, correct? We said that grading is going to, yeah, good, good. Okay, so what is this table for? The table, sorry, from this guideline, it's table 10, summary of adjuvanted treatment in early stage disease. Okay, so what they say about that? So low risk case like grade 1, well differentiated. No adjuvant treatment is required. Correct? Okay. Intermediate risk disease. What you need from the intermediate risk? You need to know that this patient will benefit from adding a vaginal brachytherapy after surgery. Okay? So what form of adjuvant therapy she will need if she had intermediate risk? Yes, yes, excellent. Okay, so the intermediate risk is going to benefit from the vaginal vault brachytherapy. Okay, and in some patients who are younger, relatively younger, and less than 60, or they have the tumor confined to the polyp only, they maybe not, okay, be advised for the vaginal brachytherapy. But in general, for intermediate risk, vaginal brachytherapy is advised as adjuvant. Okay, my friends? How about the high intermediate risk group? Look, my friends, the high intermediate risk group, okay, in the exam, usually he is going to tell you about either clearly he will say this is a high intermediate risk, or he will say, okay, that, for example, okay, stage 2 disease, okay, or stage 1, but it's had extensive lymphovascular invasion. So if it has lymphovascular invasion, even if she is early stage or stage 2, okay? So we can here go for external beam radiotherapy plus or minus vaginal brachytherapy, okay? Vaginal brachytherapy can be helpful, okay? Especially if there is no metastasis, no lymphovascular invasion, no nodal involvement, okay? If there is extensive lymphovascular invasion, even if the case is high intermediate risk, she can have chemotherapy. Why chemotherapy is going to be good in this case? I'll tell you. If there is extensive lymphovascular invasion, means that the disease start to spread or not? Yes, diseases start to spread, correct? So if the disease start to spread, systematic treatment like chemotherapy is going to be very helpful in this case, okay? How about high-risk disease, or even if we speak about cases like stage 3 or 4, where the disease already has spread? So what radiotherapy I'm going to apply? If the disease of high risk, okay, so the patient can benefit from combination of radio and chemotherapy, okay? The radiotherapy can be in the form of external beam radiation plus or minus vaginal brachytherapy and chemotherapy. And the chemotherapy in this case is the usual agent, which is the carboplatin and paclitaxel. Okay, so this is the summary of adjuvant treatment, okay, in the endometrial cancer. Okay, how they are going to give you the case in the exam, because we have a good experience with this type of questions. Simply, they are going to tell you, okay, this is well-differentiated tumor, early stage, like 1A, or this is a poorly differentiated tumor, okay? So how are you going to answer in this case? Simply, okay, you will choose for the poorly differentiated, like for example, 1B but grade 3, okay, you're going to choose the both radio and chemo, right? And if it is, for example, intermediate risk case, okay, so she can benefit from the external beam radiation plus or minus vaginal. Okay, so the regimen of the chemotherapy and radio, okay, this will be according to the center, okay? But nowadays they give the concurrent, the CCRT, okay? However, it's again according to the case and according to the scenario. They are not going to test you further, guys. Remember, you are not oncologist, okay? They are going only to ask you, okay, the common question and the broad lines of the management, okay, whether this patient need adjuvant therapy or not. Okay, so now this is, okay, the molecular classification. The molecular classification came also in the guideline. So we are still with the guideline. In the molecular classification, they give you an idea about the 4 panel that we need to test. Okay, this can come as a single best answer question. What are the 4 panel testing? Okay, so we are testing for the pool mutation, for the P53 abnormality, for the mismatch repair defect, for the non-specific molecular profile. What you need to know about each type of this molecular classification. Yeah, so for the pool mutant, we know that it's an excellent prognosis and it has a good response to immunotherapy. Well done. Okay, so P53 abnormality, it has a poor prognosis, unfortunately. The mismatch repair defect, it's an intermediate prognosis. So here, intermediate prognosis is like moderately differentiated, especially if we speak about grade 2, 1B, for example. Yeah, it's like this, okay? But the difference is once we have, okay, once we have the mismatch repair defect identified, we will understand that there is a role, okay, of immunotherapy with this patient, okay? So that's the importance of having a molecular testing. So why do you think that they pay more or extra money for the molecular testing after they have the histological grading? That's because this is will add extra benefit to the patient to direct the doctors to choose the correct treatment for this patient. Okay, so in the old days, we used to have to say adjuvant treatment, radio or no radio. Then after that came the role of chemotherapy as systematic treatment. Nowadays, it comes the immunotherapy, okay? Yes, look, my dear, pool mutation, early stage, no need for radiotherapy, okay? No rule for radiotherapy. And when I say the radiotherapy here, I mean the adjuvant therapy, okay? But it has a response to the immunotherapy, and I will say this is usually in later stage, because sometimes if it is like grade stage clinically, stage 2, but it's a pool mutation, for example, okay? So they might think about the immunotherapy for this case, okay? Mismatch repair, okay? It's intermediate prognosis, as we said, and it has a new treatment for it. The non-specific molecular profiling, this is intermediate as well. Okay? No, you shouldn't choose, Dr. Adila. I will tell you about what you choose, okay, in a minute. Please, okay, just hold on, okay, and wait. We're going to continue. There is no new adjuvant in the, okay, there is no new adjuvant in this case, Dr. DB, okay? We don't speak about new adjuvant treatment at all here, okay? So we are saying one point, okay? This one point says, okay, the case who is early stage and found to be a pool mutant need adjuvant radiotherapy or not? No. Whether saying it respond to immunotherapy or not doesn't mean give immunotherapy. Does this mean the same? No, because when they look, guys, what they do is when they have some cases like the cases with pool mutant or some cases with the mismatch repair defect, they try some treatment on them. Okay, and they found this one not responding to chemo but respond to immuno. This one is responding well to the radio. But does this mean, okay, I'm going to give it to all the stages, right? So just understanding information about, okay, okay, the characteristic of this type. What is the new recommendation in the Figo? Molecular profiling is recommended for all cases, correct? Okay, especially, okay, in stage 1 and stage 2, because it's going to make a difference in direction of the treatment. Okay, especially in grade 1, so, or 2 or 3. So we understand now there is difference between staging and grading in stage 3. In stage 1, 2, and grade 3. Okay, so in the grade 3, it has a very important, okay, rule. Why? Because grade 3 undifferentiated or poorly differentiated tumor, okay, this can be P53 abnormality, and this is going to have a different stage if it is discovered, correct? So the most one that benefit is a grade 3. Okay, for prognostic risk group stratification and for the potential use of adjuvant therapy and for the potential use of immune checkpoint inhibitors. So when I say potential use, does this mean in exam I'm going to click it? No. Okay. Okay, so what is this drug? Anybody knows what is the dostarlimab? You know, I have a very interesting video that I would like to, share with you. Okay. Yes, it's a receptor 1 blocking monoclonal antibody. Okay, so it's now, okay, a very new, trendy, as we said, medication that's been used for the cases of endometrial cancer with a special benefit to those who have MMR deficient. Okay, so those group of patients, okay, can benefit from the dostarlimab, especially when they tried this medication on some cases who have recurrent of the disease. Okay, so they found that there's a very good response. Okay, in some studies it was like 90% good response of this drug. It's used also nowadays not for the endometrial cancer only, but you know which other cancer that is very famous and very common in the Lynch syndrome or the mismatch repair deficiency. The colorectal cancer, yes, exactly. Yes, it's immunotherapy, of course. Okay, so it's a monoclonal antibody, okay, and it's, as I told you, it's one of the medications that have a very good result recently, okay? So it came in the guideline, okay, as one of the promising medication. It came also in the Figo update, okay, as one of the medications. So that's why we are doing molecular testing for the patient so we can find out which patient can benefit, okay, from the new medication, okay? The dostarlimab, my dear friends, had gained the FDA approval, okay, in February 2023, okay? And now also it has an approval in the UK after the result, very promising result in studies with a special benefit to the patient who have Lynch syndrome in both colorectal and in endometrial cancer. Okay, so this one of the medication that might come in the exam. They might even ask you, okay, about what this medication is. Okay, so we said it's a receptor 1 blocking monoclonal antibody. Okay, so might ask one question like this, or might ask you about which type of patient will benefit from this. Okay, so now, my friends, we are with the 2023 update of the Figo, which is, as I told you, it complements the guideline. Okay, there is no problem in between both of them. However, the guideline has published, okay, the latest or the older, okay, version of the Figo, but the recommendation for management of the cases is still the same. Okay, only thing here that the staging, the surgical staging changed, okay? And the molecular staging, okay, can even, okay, change the names, and we will find out how. Okay, so my friends, please focus with me. The Figo classification 2023, okay? Here we go. The molecular classification of the Figo 2023 now subdivided stage 1 into 1A, 1B, 1-3, okay? And in 1A, you will find even 3 substages, okay? So in general, stage 1 speak about the tumor confined to the uterine corpus and ovary. And this is a very big question mark that I'm going to answer in a minute, okay? Okay, so disease limited to the endometrium or non-aggressive histological type, this is 1A, okay? Like low-grade endometrioid cancer, okay, with invasion of less than half of myometrium, with no or focal lymphovascular invasion, or good prognosis disease. Oh my God. This is a lot in 1A. Yes, it is. But let's just, you know, have it like in one piece or in chunks, and it will be clear, inshallah. How? I'll tell you. First of all, when I say the disease limited to the endometrium, okay, or less than 50% of myometrium, okay, and it's a non-aggressive histological type. So guys, please tell me which grade is non-aggressive? Grade. Okay, grade 1. Okay, is grade 2 also non-aggressive or not? Grade 2 is still non-aggressive, right? Okay, it's moderate, but it's moderate, but not aggressive. Okay, okay. So non-aggressive histological type or low-grade endometrioid. So low-grade endometrioid, that's clearly grade 1. Excellent. Okay. With invasion less than half of the myometrium or no focal lymphovascular space involvement. Okay, with no or focal, yeah, means that there is no lymphovascular involvement or focal only. Okay, or good prognosis disease. Which good prognosis disease is? Do you know? Anybody know what is a good prognosis disease? Pull, yes. Well done. Okay, well done, Dr. Mariam and Dr. Ziggy. Okay, so let's see the substages. Okay, well done, everyone, Dr. Maria also. So 1A1. 1A1 means, look here, non-aggressive histological type. Do you agree? Limited to endometrial polyp or confined to the endometrium. So no myometrium, no myometrium. It's non-aggressive. It's a good type, okay? But only to the polyp or endometrium. No myometrial invasion, okay? Good. 1A2. 1A2 is non-aggressive histological type, involve less than half of the myometrium with no or only focal lymphovascular invasion. Okay, guys? So here, when I say I have a well-differentiated tumor, okay, less than 50% of the myometrium. Which stage is that? 1A2, well done. Okay. 1A3 is low grade endometrioid. Look here, he make it not histological type. No, he said endometrioid. Okay, carcinoma limited to the uterus and ovary. Oh my God, again and ovary? Yes, again and ovary, and I will let you know this. Okay, so they found some tumor cells in the ovary, but not a physical extension of the tumor to the ovary. You get the point? So, low-grade endometrioid carcinoma. Okay? Low-grade endometrioid carcinoma. What is the type of it? With myometrial invasion, correct? Okay, good. So this is 1A3. How about 1B? What is 1B now? 1B is non-aggressive histological types with invasion of half or more of the myometrium and no or focal lymphovascular invasion. So when I tell you the very famous cases of the exam, you have a case, okay, diagnosed with endometrial cancer and it found to be of endometrioid type. Endometrioid is good, right? Or at least non-aggressive. Grade 1, okay, and it's the tumor invade 50% of the myometrium. What is 50% of myometrium? It's 1B, okay? Great. What is 1C? 1C, they make it now like this, my dear friends. When they divided the tumor, okay, they got a tumor confined to the polyp or endometrium, no myometrial invasion, okay? If it is good type, non-aggressive, we will call it 1A1, okay? But if it was aggressive type, okay, we will say that this is the 1C, okay? So only limited to the endometrium, but aggressive. So what I'm going to call this? No, I'm not. Okay. So my dear, okay, so you know the Figo, okay, all the Figo panel, okay, they are sitting together to give the new updates after works, years and years of research and work. So they give us the stages, okay, and I don't have any, any influence that I'm very poor, okay? MRCG mentor, and I'm just delivering the message to you, my dears, okay? I'm not trying to make your life, more difficult. I know you have exam after a couple of months, but just cheer up, okay, and know the trick, so you will answer it. I feel what you feel because the first time, the first time I read this guideline, really, okay, it was me and Dr. Nada on a Zoom meeting. We have a private Zoom meeting together, okay, and it was like a continuous Zoom meeting for one day, okay. So we go for prayer and come back. We go for pick up the children from school and come back, So we had one day off, both of us, okay, of work, and we stayed only to read the guideline, okay? Same thing happened for the Figo, and that's mean, and it has like 1 week work trying to get it to get all the updates and information, plus attending meetings and conferences, reading articles here and there, all of this to get just the idea, okay, of what they are doing. So trying again, my dear friends, to make it simple to you. Inshallah, it will be simple, okay? 1A, again, is subdivided into 3 substages. In 1A1, this is a tumor, very small tumor, okay, very tiny. It's in the endometrial polyp or the endometrium only, no myometrial invasion. But the good thing is it's a non-aggressive, so prognosis is excellent. In 1A2, it's a non-aggressive, but involve less than half of the myometrium. In 1A3, so they made this one specifically for a special case scenario where there is some cells of the endometrioid tumor found in the ovary along with the uterus as well, okay? In 1B, 1B is non-aggressive histological type still, but with 50% or more invasion of the myometrium. 1C, from here we started the aggressive type. So they added the C to the stage for the aggressive types, okay? So aggressive type here, but confined to the polyp or to the endometrium. So that can be a tricky exam question when they tell you that a tumor, okay, a patient had a postmenopausal bleeding and for example, the endometrial thickness was 5, they have decided to take a sample, they send sample to the lab and it show poorly differentiated histological type, okay, and by the MRI, it found that the tumor is only confined to the endometrium. What stage is this? So stage is 1C. How does this affect the treatment? This affected the treatment means that this case need adjuvant therapy after the surgery. Okay? So that's why they have subdivision. So every stage will give you an idea about the pathway of management. Okay? Okay. Now we go to stage 2. In stage 2, invasion of the cervical stroma, okay, without extrauterine extension or with substantial lymphovascular invasion or aggressive histological type with myometrial invasion. Okay, so here, 1 second, we are going to take each case of this and try to understand what it is. This is invasion of cervical stroma, but no extrauterine extension, okay? So only cervical stroma is mentioned, okay? Nothing else. So it's stage 2. Or a tumor with substantial lymphovascular invasion. Okay, so you remember in stage 1, all stage 1, there was no substantial lymphovascular invasion. So once we have substantial lymphovascular invasion, no matter the size of the tumor, it's now confined to the uterus. It's now stage 2, okay? We left stage 1, bye-bye, and now we are in stage 2 because of the substantial lymphovascular invasion. Remember, my friend, substantial lymphovascular invasion will benefit from chemotherapy or not? Yes, it needs adjuvant and not only local by the radio, it will need systematic by chemo. Okay? Okay. Or aggressive histological type with myometrial invasion. So do you remember the aggressive type? Last thing was appearing here in 1C. In 1C, we have aggressive histological type, but it was very tiny to the polyp or endometrium. Now we have the aggressive type, but with myometrial invasion. So please be careful when you solve the case in the exam. Now, if you have a case 50% invasion, but it's aggressive type, which stage is this? 2, and which 2? Is it 2A or 2B or 2C? So we said aggressive now means C. Okay, it's a stage 2C. Okay, good. So see, things changed dramatically. It was in the old 1B, right? Now it is 2C in the stages. Okay. So my friends, let's see the substages of 2. 2A, invasion of the cervical stroma of non-aggressive histological type. Okay. You got this? Yes. 2B is substantial lymphovascular invasion of non-aggressive histological type. You got this? Once we said substantial, we are now in 2B. 2C, aggressive histological type with any myometrial invasion. Okay? So less than 50%, more than 50%, it doesn't matter. This is aggressive histological type. You got, my friends? Okay? So non-aggressive tumor can be 1A, 1B, or can be 2A or 2B. But once it's aggressive, it's stage 1C or stage 2C. Okay? I hope you're not lost. Okay. So, use of molecular profiling in upstaging and downstaging, stage 1 and stage 2. Okay, this is after the Figo classification, which depend on the histological and the surgical staging. Molecular staging even can come and change the stage another again. So when the molecular testing appear, the immunohistochemistry result appear in the disease, we can say different, okay? How? I'll tell you. They give, okay, the P53 abnormality when it is confined to the corpus, okay? We say this is now stage 2C, and we added M for it. M means it has molecularly tested, and we had the result of the molecular testing. It's P53 abnormality. How does this, they are going to ask this in the exam. I think will be like just a direct question to assess the knowledge, to find out who know the updates and who does not. Okay, so they will ask you about the meaning of this. So stage 2C, P53 abnormality. Okay, so this is a tumor that confined to the corpus or the cervix, and it's a severe type, correct? It's a poor prognosis. In stage 1A, pool mutant, this is a tumor, okay, of a good, okay, prognosis. So regardless the histological type, regardless the degree of lymphovascular invasion, once it's a pool mutant, we are happy. Okay, we have a good prognosis now. Again, you just know this piece of the information, okay, because this piece of information is a special case scenario, right? This is how they show you the molecular testing can change the staging. That's it, okay? Can we have some exercise, please? A little bit of exercise. And by the way, this was a published, this exercise comes from a published, article. So the next 3 patients were staged as uterine cancer stage 1A based on the old Figo staging system. Now you need to restage each case according to the 2023 Figo update using option from the following. Okay, so this is the options, and here the case number 1. Case number 1, the first case, A, okay. First, the patient had endometrioid type, grade 1 endometrial adenocarcinoma without myometrial invasion. So if I ask you, my friends, for this case, what is the 2023 Figo staging for it? Yes. Excellent, excellent, excellent. It's 1A1. Excellent. Well done. Yes. Okay, next case, 1 second. I hope you can still see the screen. In this case, second patient had endometrioid type grade 1 endometrial adenocarcinoma with less than 50% of myometrial invasion. What is this? This B in the arrow. So we used to call this 1A in the past. So grade 1 endometrial adenocarcinoma with less than 50% of myometrial invasion. The second patient had endometrioid type grade 1 endometrial adenocarcinoma with less than 50% of myometrial invasion. Can you guys see the screen or not? If you want to see options, here are the options. No screen. Okay, I'm sorry. Again. Can you see the screen, my friends? I'm trying to refresh. Okay, good. So this is the stage, this is B. B says second patient had endometrioid type grade 1 endometrial adenocarcinoma with less than 50% of myometrial invasion. Grade 1, aggressive or non-aggressive? Non-aggressive, okay. Less than 50% or more? Less. Okay, so it's 1A2, excellent. Excellent, okay. Third case. The third patient had endometrioid type grade 3 endometrial adenocarcinoma. Okay, forget about the molecular group now, just for the staging, with less than 50% of myometrial invasion. Less than 50% of myometrial invasion, but it's type 3. Yes, so it's not 1C, my dear. 1C is for the aggressive limited to the polyp or endometrium. Once the aggressive invade the myometrium, it's become 2. And because it's aggressive, it's a 2C, right? No worries at all. You have all the time to make mistakes now. Okay? Okay, dear. Okay, so 5 minutes quiz, my friends. I'm going to show you the questions. Okay? And you're going to see 4 or 5 questions on staging. Please write it down, okay, in a piece of paper. Don't share it on the chat box, okay? Just write it down and test yourself, okay? We'll have 5 minutes only to do that. It's a small exercise. So my friends, please tell me, how did you solve the questions? Okay, so for the case here, for the question 4, the lady who had the total laparoscopic hysterectomy and bilateral saphenophractomy and biopsy-proven endometrial cancer, final pathology report described the endometrial carcinoma confined to the inner half. Inner half of the myometrium, is it 50%, less than 50, more than 50? What do you think? Okay, so it's a half, so simple. Okay, so what was your answer, my friends? One A1. Okay, so it has a myometrial invasion. Okay, so the non-aggressive histological type involve less than half of the myometrium with no or focal lymphovascular invasion, it will be 1A2. If it is half of the endometrium, non-aggressive histological type with invasion of half or more of the myometrium, so it's 1B. Correct? So how many of you answered correctly? I don't want to know the answer. Okay, keep it yourself. Just, okay, take a note for the question. Okay. At time of hysteroscopy, abnormal lesions were found in the uterus at the cervix. So I have here extension to the cervix and also to the upper portion of the vagina. MRI scan did not show any pelvic spread. Otherwise, biopsy of this lesion showed adenocarcinoma consistent with endometrial origin. So, dear friends, let's see the stages of 3 and 4. In 3 and 4, in 3, we have a local and or regional spread of the tumor of any histological subtype. So here they stop saying aggressive, non-aggressive. It's now speaking about the surgical, okay? In 3A, invasion of uterine serosa. And I remember one of the exam cases was recently about the staging. It was asking about, asking about the spread to the serosa. So it's 3A, adnexia, or both by direct extension or metastasis. In 3A1, spread to the ovary or fallopian tube, except when meeting stage 1A3 criteria, okay? In 3A2, involvement of the uterine subserosa or spread through the uterine serosa, okay? So in sub-stage of 3A, it's a 3A2 when it is uterine serosa. In 3B here, okay, is direct spread or metastasis to the vagina and or parametria or pelvic peritoneum. So the case was 3B, but let's see, it's a 3B, 1 or 2. In 1, there is a metastasis or direct spread to the vagina and or the parametria. In 2, 3B2, metastasis to the pelvic peritoneum. So our case was the vagina. So it was 3B1, right? In 3C, further stages is metastasis to the pelvic or para-aortic lymph nodes or both. So here they speak about the lymph nodes. Once he mentioned which type of lymph node involvement in the endometrial cancer, you are in 3C. If it is pelvic lymph nodes and micrometastasis less than 2 millimeter, it's 3C1I, okay, or 3C11. And 3C1, okay, 2 is macrometastasis. Macrometastasis means 2 millimeter or more. Okay. If it is para-aortic lymph node, so it's a substage of 3C2, okay? And again, it's subdivided into micro or macrometastasis. Take care in the exam. Once mention type of the lymph node, you know now we are in 3C. Stage 4, 4 means it's distant, you know, metastasis or spread to the bladder mucosa or intestinal mucosa. In 4A, invasion of the bladder. and or the intestinal or bowel mucosa. 4B, it's beyond the pelvis, abdominal peritoneal metastasis. 3 is distant metastasis, like an extra or intra-abdominal lymph nodes, okay, or brain or bone. So very far metastasis is 4C. Okay, my friends, this is regarding the advanced uterine cancer stages. In this question, poorly differentiated endometrial cancer. So poorly differentiated, it's aggressive usually. It has invaded more than 50% of myometrial thickness. So what's your answer for this? It's now 2C, okay? That's very clear. And this is the most likely questions that can come from staging because this is a new part in the staging. Well differentiated, okay, good. Endometrial cancer treated by simple hysterectomy and found to have large pelvic lymph node, which sample and found to contain metastatic cancer. No other evidence of metastasis is found. So he didn't mention, okay, which one of the lymph nodes involved. So what's your answer now? Once the large lymph nodes, okay, is found, the pelvic lymph node, okay, so it's a 3C. Pelvic lymph node take 3C1. Para-aortic lymph nodes take 3C2. Okay, so if it is 3C1, will you give it the first one or the second one, micrometastasis or macrometastasis? It's of course 2, the second one, 3C1, 2. Why? Because it was large, it's macro. It's definitely more than 2 millimeters. Right? Okay, my friends. Okay, I hope that you found the uterine cancer or endometrial cancer update is easy. Okay. Otherwise, I advise you that you, of course, go through the important point that is related to the endometrial cancer, which is interesting to the examiner. Like, for example, I told you that detecting endometrial cancer, TUG article is important. Management of postmenopausal bleeding is very important. Okay, so look into those things. Very helpful in your study and for your exam, inshallah. Okay, thank you so much. Okay, and I will ask you for 5 minutes.